All right, we're here with Dr. Krishna Rayapudi talking about the TOR-E procedure or the Transoral Reduction Endoscopy procedure. When patients come into our clinic, what are some things that you are assessing? And also, is there any pre-testing that needs to be done before this procedure?
So TOR-E is a Transoral Reduction Endoscopic. So it is used in gastric bypass patients to help them lose more weight. So when they come into the office, we assess them globally if most people have diabetes because of their excess weight. So you're checking how bad is their diabetes. Are they good risks for endoscopy? Are their sugars controlled, not controlled? So because they need to be at least somewhat controlled, so the procedure is not high risk. Are they having bad reflux symptoms?
Okay.
And the next thing is we also want to make sure that if they have bad acid reflux, right, and how bad it is. And then is there dumping syndrome? Dumping syndrome is where they feel symptoms immediately after eating. Sometimes it's a few minutes after eating, a little longer, but we assess those symptoms of dumping syndrome. Are they having trouble with swallowing food? Then that might be a problem. So we assess all those and we get a set of labs that are required. And then we assess their medications. And then the next thing is we do a screening endoscopy where we pass a scope and look to make sure the anatomy is good for the procedure. A psychological assessment also needs to be done prior to the procedure.
So you mentioned a little bit about assessing medications. We're hearing a lot these days about new medications out there for weight loss. Can those be combined successfully with the TOR-E procedure?
That's a good question, Bobby. So, yeah, there are a lot of medications nowadays. So, the good part about this procedure is you're not limited to just this procedure alone to help you lose the weight. You can combine medications with this, and it gives you an enhanced weight loss. Better than just the procedure alone. But I usually recommend it for patients with higher BMIs, and we have to look at all their history and medications and everything, and we make a recommendation. But the short answer is yes, it can be combined, and you can do both of them together for enhanced weight loss, and that should make it easier to reach your goals.
Oh, that's fantastic. I would like to talk a little bit more about why someone would choose to get the TOR-E procedure endoscopic. What would make them do the endoscope versus the surgery?
There should be some advantages, Bobby. So then patients are trying to choose this one over surgery, but both are effective. But there are some advantages to this TOR-E procedure over surgery.
Okay.
The adverse event rate is almost half compared to surgery, and this is data based on studies. So the adverse event rate after this endoscopic procedure for stoma reduction compared to surgery is almost 1/5 compared to surgery.
Wow.
So you're avoiding a lot of adverse events by doing it this way.
Okay.
But remember, not every patient qualifies, but whoever qualifies, it'll be a good option since same-day discharge and it's an endoscopic procedure. But just a big picture for patients is when you do endoscopy, the recorded serious adverse events were almost 0%.
Wow.
And compared to surgery, which is standing at 19.4% in studies, close to 19%.
That's pretty significant.
Yes, so it offers great advantages by doing it this way. So the conclusion is that the amount of adverse events, serious adverse events, are much lower with the endoscopic procedure, and the amount of weight loss retained at the end of 5 years is still the same.
It's still the same. Okay.
So it gives you best of both worlds.
So what are some other things that would exclude a patient from getting the TOR-E procedure?
So there are other things that can exclude patients who come for this procedure, which is if they had a banded Roux-en-Y gastric bypass, like if they had a band placed on top of the stomach, that's like an older procedure, then the stomach is altered and it's no better not to do in those patients.
Okay.
And the other thing is if they have active substance abuse, like cocaine, heroin, those are excluded.
Okay.
If you're in immunosuppression for any reason with cell counts that are dropping, this will be a problem. And any active medical conditions that would preclude suturing, or even a severe acid reflux causing a lot of erosion at that G junction with the gastroesophageal junction, which will prevent me from putting the scope down or interrupt the suturing process.
Okay.
And the other thing, again, when we put the scope down, you're looking inside for problems. So if there is a huge ulcer at the stoma site, which is the gastrojejunal anastomosis, so if there's an ulcer that can form at the anastomosis site, then you can't really suture, or even if you suture, it won't stay in place. Or sometimes it can even perforate the thing there. So that's why when you come in, sometimes I wouldn't know until I put the scope down, or we have to consider doing a screening endoscopy where you do a scope first, make sure everything checks out, and then bring you back a different day to do the procedure. So we can choose either route. Sometimes it depends on the patient, and depending on if they had a recent endoscopy, we can look at those pictures and decide. But those are general exclusions for the procedure, which in detail, if you go in more detail.
Now, we mentioned what patients would need to qualify for the procedure, what would exclude patients. What are some contraindications to getting the transoral reduction endoscopy?
There are situations where the scoping is contraindicated. Like, let's say they have a medical problem where they won't be stable for an endoscopy. That is a no-brainer, so you cannot do an endoscopy on them. And the other thing is if they have cancer.
Okay.
I mean, with the time of bypass, you'd have been fine, but if you develop cancer after, or if there's some malignant tissue in the area where you're going to do it, it's an obvious contraindication.
Okay.
And there is also big hiatal hernias. The hernia is like when the stomach comes up above your diaphragm, and then we call it a hernia.
Okay.
And if it's big, then that'll cause issues with the technique.
Okay.
And so you don't want to do it on those patients. The other thing is if someone has a underlying eating disorder or a psychiatric condition, which would prevent you from following directions or prevent you from sticking with the dietary recommendations, then you cannot do it on those patients too. The other things are if in pregnant patients, obviously don't want to do it, or patients who are on antiplatelet therapy like Plavix, Eliquis, they're usually higher risk for these procedures.
Okay.
Or anticoagulant therapy like warfarin, etc., they're generally contraindicated because of the amount of bleeding or complications that can happen during this TOR-E procedure.
So we just want to make sure that we're being as safe as possible for the patients.
Right,
correct?
right, yep. Safety comes first.
Yes.